Every physician in America has experienced the squeeze of third-party intrusions into their daily practice of the art and science of medicine. As an ophthalmologist, there was one particular day when I realized that I could no longer continue as a preferred provider for any commercial insurance. It was with the arrival of a fax from an insurance company concerning a medication that I had ordered for my patient, whom I'll call Mrs. Jones. I've cared for Mrs. Jones for the past 15 years, having diagnosed her with moderately severe glaucoma. Fortunately, with close monitoring and the innovative panoply of wonderful glaucoma medications we have, her glaucoma has been arrested effectively with topical treatment. Fast forward to the day of the Epiphany. I received this CVS Caremark form entitled Brand Penalty Exception Request. Let that sink in. On it, I was to attest that I had tried 2 generic medications that failed to control Mrs. Jones' glaucoma, or my patient would be subjected to the, quote, punitive brand name charge versus the appropriate brand name charge. For those who missed the ophthalmology rotation in medical school, to prove that a glaucoma medication has failed is to show that there has been irretrievable loss of more of the nerve fiber layer of the retina. To knowingly remove a controlled patient from their drug to run a trial of 2 generics is morally and ethically reprehensible. To fill out a form and lie is committing fraud, and it's also embracing the idea that the end justifies the means. This one fax that I received finally laid bare the ruthless, heavy-handed blackmailing of physicians by threatening physical and, financial, as far as I know, they haven't taken a bat to anyone yet, financial punishment of their patients. So as of November 30th of 2015, I divested myself from all PPOs and became an out-of-network physician provider for all commercial insurance. Here is the letter that I sent to all of the commercial plans. And you can read it there for yourself, and I have a copy of it if anyone would like it. More on my stance on Medicare later, and Dr. Woodhams is going to talk about the difference between opted out and disenrolling. But I was already a non-participating provider physician, so those patients were accustomed to paying me for services rendered and being reimbursed from Medicare. And my employees were very comfortable with collecting fees at the time that services were rendered because of this arrangement. This brings me to the purpose of my presentation. I would like to share my plan for transitioning from third-party dependence on the commercial side and what every single physician in America should consider immediately at minimum for Medicare. Probably the most important step in achieving the will to make this change is to take 1 week to have all of your employees and yourself pay attention to the time spent processing fax and phone requests for generic substitutions, pre-certifications, proof of coverage, denial appeals, etc., etc., etc. I suggest you even give yourself and your employees stopwatches. During this week, have your office manager pull the payment amounts for several selected procedures and office visits from all commercial insurance in which you participate, as well as Medicare. Compare the payments. You may be very surprised. I found several of the major insurance companies were paying 80% of the Medicare rate for certain procedures. My office personnel had not noted this downward trend, as many payments come in bulk. There's a variation in patient co-pays and deductibles, and reconciliation does not display the previous payment rate. Well, when I shared what I found with my anesthesiologist, he investigated his practice and discovered that Humana was paying less than Medicare for a very common procedure, and none of his billing people had caught the decrease either. So I had a situation where the demand on my time for insurance issues was increasing. The intrusion into the practice of ophthalmology was best described as coercion to falsify information or have my patients be financially penalized, and I was being paid less than Medicare in many instances. With this added information, my resolve was set in stone. It was definitely time for a change. No change like this can be undertaken without careful planning, which includes your employees, your patients, and you. Getting your employees on board and enthusiastic is of utmost importance. The good news is that they despise the hassles as much as you do. The bad news is that all change is stressful, and their concerns about job security and the solvency of the practice cannot be ignored. Involve them in the planning and in the transition. Point out what insurance has done to your practice, to their workday, and to the ability to offer your patients individually crafted care. They need to be very comfortable with cash transactions, discussing fees, helping people make financial arrangements if necessary, and how to explain the new policies. All employees with any patient contact were involved in the transition. I actually made a template of the way that I wanted our policy to be presented on the phone and in person. We actually had practice sessions. Once we made our transition, I solicited feedback on how our patients were responding, and we changed things as we needed to. Now, as the boss, your most difficult job is to create a cash fee schedule. And actually, this is more difficult than it seems at first, because the non-Medicare payments are not what you've actually been paid, but rather a percentage of that. I looked at my non-Medicare fees and my non-participating provider Medicare fees for my most common procedures and services. Next, I looked at the physician's fee reference by Wasserman Medical Publishers for the 50th and the 75th percentile fees for the codes I use, and then this was an excellent exercise for me. I spent a good amount of time determining what was fair and sustainable as a fee for every service that I rendered, and I based it on time required, complexity, usual and customary fees, and resources utilized. The result was my personalized transparent fee schedule, which I posted on my website, and I included it in the letter I sent to every single one of my patients 2 months prior to instituting this transition. This brings me to patient involvement. You will lose patients, but take heart. They will be replaced. But how you notify them and how you handle the transition will determine how many. No one likes a financial surprise, and I think it's imperative to inform your patients before they arrive the day of the visit. I sent a letter to all of my patients, as I mentioned, and in my letter I did include my experience with Mrs. Jones as part of the reason for my decision. And as always, my staff and I are careful to say that we are an out-of-network practice for all commercial insurance, being very careful never to say we don't take insurance. Share with your patients that you recognize that they or their employer have paid for their insurance and that you will help them recover out-of-network reimbursement. I do this by filing all claims for the patients with any reimbursements going to them, which is usually about 50 to 60%. This has not increased my overhead since I was filing prior to the change, and I don't want to let the insurance companies off the hook. Many patients will find that there is only a small increase in their out-of-pocket expense to see me when they consider their copay and their high deductible when they use their insurance. We do also offer payment plans for those in need, and I no longer deal with insurance regarding generics, but rather have these discussions and options with my patients. Now, don't think the insurance companies are going to take this lying down. One thing I wish I had included in my patient letter is a warning that the insurance companies will send a letter to them saying that I am no longer in network, so they cannot see me and must choose another provider. I wouldn't have actually known this was occurring, except that I had several savvy patients who realized that they had contracted for out-of-network options. Finally, and this is an important point in terms of your attitude and your employees' attitude, Reassure your employees that you are growing the practice under a new structure to promote the attitude that you're building something better and all growth takes time. Now, regarding Medicare, the passage of the Medicare Access and CHIP Reauthorization Act, MACRA, presents an ominous threat to the solo and small practices and ultimately to the private practice of medicine, period. In my opinion, these are the steps that every physician should consider immediately. First, become a non-participating provider at minimum. The next opportunity to do this is November and December of this year. This means the patient pays you at the time of the visit, you file as usual, and Medicare reimburses the patient. This has several advantages, one of which is that you are paid at a slightly higher rate than accepting assignment. Now, everyone needs to understand about participating and non-participating as a Medicare provider, and everything you need to know is on this slide from the CMS website. I will explain it, but as you can see, we have all adjusted to a very convoluted system, and most of us without even understanding it. As you know, a participating provider can charge anything they want for a service, but Medicare only pays 80% of Medicare's determined fee for that service, and the secondary only picks up the 20% remaining between Medicare's decided fee and the 80% that they pay. The physician bills for the patient and is paid directly from Medicare and the secondary. The remaining balance from what that physician charged and what Medicare paid is written off by the physician. Now, there's two numbers there for the non-participating provider. As a non-participating provider, there is a limiting charge, and that amount is the only amount that you can charge for that given service. The patient pays that amount, which is the bottom amount on this slide, at the time of the visit. You file with Medicare, and the patient receives reimbursement from Medicare and their secondary in that middle amount shown. Now, as you can see, the actual limiting charge translates to 9.25% more than the payment that was given to the participating provider Medicare physician. The difference in this payment is covered by the patient when they pay you the limiting charge amount at the time of the visit. That is their out-of-pocket expense. Remember that 9.25%. This arrangement restores the concept that your contract is with the patient for care and their contract is with Medicare for reimbursement for promised benefits. You will have the option to accept assignment on a case-by-case basis as needed, and you will find that the patients become much better stewards of their health care dollars, even though they are going to be reimbursed, and you will too, because the questions will shift from does Medicare pay for it to include how much does it cost, why do we need it, and will you tell me ahead if extra testing is necessary. And finally, it sets you in a much better position to opt out or disenroll in Medicare when that time arrives, and without substantial reform, that time will arrive. Second, for as long as possible, do not comply with any of the financially rewarded mandates. The EMR meaningful use, the PQRS, the electronic medical record, the electronic prescriptions. Take the fines, which result in less financial loss than compliance. As you could see from that CMS slide, by becoming a non-participating provider, you will increase your Medicare payments by 9.25%, enough to offset even the 2019 MACRA fines. Your bottom line, your mental health, and your practice enjoyment will instantly improve. A recent study from the Department of Healthcare Policy at Weill Cornell Medical College in New York City, as cited in Medscape in March of 2016, found that the average cost of quality and computer compliance reporting and usage per physicians was $40,000 per year. The authors estimate this translates to hundreds of millions of dollars in annual spending by physicians. One can only imagine the concomitant bureaucratic expense of tracking all that physician data. And this is even before the MACRA escalates demands for reporting and alternative practice patterns and links them to bonus payments. Any physician who takes these bonus payments is at market increased risk for audit and recoupment payments, as is already occurring for meaningful use 1 and 2 of the mandated electronic medical record. Also, when the payment goes to the patient, it will be very difficult for CMS to take money from future billing to solve their discrepancy if they feel like you have overbilled. I was part of a task force that read 962 pages of the CMS MACRA rules, and Chris Held did the yeoman's work. She read all of them. I got off easy. I only had 100 that I was supposed to read and critique. And by unanimous opinion of those of us on that council, no practice will be able to comply, and attempts to do so will lead to financial and professional ruination. Interconnected EMR, connected to CMS as required by MACRA for good ratings and bonus payments, marks the end of our privileged communication between the patient and the physician and strips patients of privacy and dignity. And this is all done under the guise of mega data collecting and eventual best practice rubrics for population health to keep people healthy. Well, maybe the government should be eavesdropping in the priest's confessional so we can stamp out sin, and maybe in the lawyer's chamber so we can eliminate crime. Finally, when the fee reduction for non-compliance becomes unsustainable or compliance becomes mandatory, period, you will be in a much better position to exit Medicare. Prior to that, be proud of your 0 rating by CMS, become a medical Gandhi, and share why with your patients. Peaceable resistance. The decision to continue in any capacity at all in the Medicare program is a very personal one based on many factors. For me, I am a dissident in that I do not comply with the PQRS, EMR, ERX, but rather I take the fine. This satisfies my need to remove myself from the ridiculous mandates, not to mention saving me thousands of dollars per year. This has also allowed my team and me to focus our time and energy on our patients. My patients pay me, and I have never taken a Medicare reward, making me much less of a target for recoupment or audit. One fact people often forget, and actually this weighs very heavily on me: Medicare patients did not choose Medicare. Medicare patients are conscripts in the Medicare Insurance Brigade, and they are treated as such in the MACRA law, which actually treats them as little widgets. They have had money removed from many years of wages with the promise of health care benefits at the age of 65. Now, in a rare act of true government genius, the average life expectancy in 1963, when Medicare was passed, was 69 years of age. The government has betrayed them, and now many of them are paying as much per month for their Medicare insurance, which the government calls a benefit, as they were for their private insurance prior to Medicare. Therefore, as long as I am able to offer state-of-the-art care to my patients, protect their privacy and the sanctity of our therapeutic relationship, and remain financially solvent, I have made the decision to continue as a non-participating provider so that my patients can get reimbursement from Medicare. For example, I am able to offer state-of-the-art cataract surgery with access to every intraocular lens on the market by balance billing, which was legalized by Congress to afford patients access to this newer implant technology. This allows even modest income patients to enjoy these advanced lenses with modest out-of-pocket charge, while Medicare pays for the procedure and the baseline lens charge. I make less per case than an opted out or a disenrolled physician, but many patients are not in a position not to use their Medicare. In closing, rather than listening to the hype and hysteria coming from people and many of our own medical and surgical organizations trying to sell you compliance tools for MACRA, meaningful use, PQRS, etc., or insurance companies hammering you with untenable choices and threats, start today to channel your energies into taking the steps necessary to transition into an ultimate freedom from all third-party intrusions. I will gladly share my patient letters, my insurance letters with anyone that's interested, and I hope that this starts you on the road to a more fulfilling and a less stressful practice environment. In the meantime, it is imperative that we continue our unrelenting efforts to get insurance and the government out of the practice of medicine by offering patient-centered, physician-guided, free market solutions for reform that must include choice for our Medicare patients as well. I've tried to cut these